All right, well, welcome. I'm Paul Zeeb, I'm your medical director, and today we're going to have a conversation regarding the evolution of emergency care in Central Ohio, focusing mostly on freestanding emergency departments. We have two guest speakers today. I will let them do their own introductions.
Hello, my name is Ben Stoyak. I work in the Mount Carmel Health System. I am the medical director over at our freestanding emergency department in Reynoldsburg.
And my name is Ryan Squire. I'm a board-certified emergency medicine physician that works within the Ohio Health System and the associate medical director of the Ohio Health New Albany Freestanding Emergency Department.
Ryan, take it away.
So our objectives today, obviously in the last decade and a half, emergency departments within Central Ohio and even across the United States have a different feel, especially as we've seen freestanding emergency departments step into the space. Freestanding emergency departments are a different structure than our typical hospital-based emergency department. They have different capabilities as well as different staffing models. Here in Central Ohio, as compared to what we might see in other areas around the country, we do have freestanding emergency departments that are a extension of our main hospital systems. In particular, with regard to our discussion today, talking about what those freestanding emergency departments look like within the Mount Carmel system as well as within the Ohio Health System. The importance from an emergency medical services standpoint is understanding what those capabilities are and understanding there may be instances where it may be best getting a patient to perhaps a main hospital-based ED because of resources that a patient may need. And our goal with even the Central Ohio Trauma system is making sure we get the right patient to the right place the first time. And our goal today is kind of discussing some of those nuances from those that work within the confines of the freestanding emergency departments.
So what is a freestanding emergency department? As you can see on the slide, it's a facility that receives individuals for emergency care and is structurally separate from a hospital facilitated or emergency room facilitated, a hospital facilitated emergency department. So the evolution of emergency department care in Central Ohio has been broad and speedy. In the last 10 years, there's been quite a fundamental change in how patients are received in emergency departments. For a long period of time, it was primarily hospital-based, and over the last 10 or 15 years, there's been a strong surge in the number of freestanding emergency departments in Ohio and in Central Ohio. Ohio in general has one of the most freestanding emergency departments in the country, and specifically in Central Ohio, there's been at least 10 freestanding emergency departments that have opened through the Ohio Health and Mount Carmel Health System as ways for patients to receive quick and speedy care and appropriate care. And hopefully this discussion today at least guides you and helps you understand the capabilities of what we see and can do in those emergency departments. So what is ACEP, or the American College of Emergency Physicians policy on freestanding EDs? It's pretty basic, and there's a list there. In general, they have to be or should be staffed by a board-certified emergency medicine physician and have at least one registered nurse on site at that facility. They have to be it's protocolized in terms of how they can transfer patients to receive definitive care in terms of surgery or critical care services. But in general, it's pretty basic, which leaves a wide variety of models which are very similar among the Mount Carmel and Ohio Health System. Some of our sites provide pharmacy services, respiratory therapy services, and other services. But in general, you know that if you're taking a patient to a freestanding emergency department, there will be a physician there as well as a nurse that you can hand off care to.
And it should be noted too when we talk about freestanding emergency departments and anything that bears that sign emergency kind of in red letters on it, that it is governed by EMTALA, meaning that if someone arrives at that site for care, whether by private vehicle or by ambulance services, they are going to be provided that care and will at minimum receive a medical screening examination. And so that is something, obviously the freestanding emergency departments around Central Ohio, we all take EMS traffic, and we have an obligation to the patients that arrive there. Our goal today is understanding, one, that if you do, take traffic, to any emergency department, the goal is, to make sure that facility provides care. We do have, diversion, and I believe, we went off diversion the morning of, of this recording, but by the time you guys listen to this, there's a good chance we might be on citywide diversion again. And the importance in Central Ohio is, citywide diversion is not a firm, stance. It is a recommendation, to help with some of the volumes that are present within the emergency departments across the city. And arguably, with the number of beds that have opened in the freestanding emergency departments in the past 10 to 15 years, our main hospital EDs would be overwhelmed to a whole nother extent than what we're seeing nowadays, because we have opened in excess of 100 beds to receive emergency care across both health systems that aren't within a hospital-based emergency department. This particular slide, we're looking at that continuum of care that exists. This is kind of Ohio Health's continuum of care, but it mirrors Mount Carmel's as well. Understanding that our lower acuity patients seeking care within the confines of an urgent care, and then seeing a freestanding emergency department, which will be above the level of care that we can see in an urgent care. And I would, for the nature of this discussion, as well as understanding Central Ohio, Ohio State's immediate cares would fit right between those two, the urgent care and the emergency department. Understand they are not open 24 hours a day, but they do have increased capabilities, many of which mirror what we see in our freestanding emergency departments. And then within Ohio Health, we have freestanding emergency departments that are on a medical campus, which in current state would be like our Westerville campus, which does have some increased capabilities, including the ability to keep some patients overnight, but does not have the full capabilities as well as the full specialty backup that we'd have at one of our main hospitals, that would include Mount Carmel East, Riverside, Mount Carmel St. Anne's, Grant, that have increased capabilities to provide care, increased specialty on call 24 hours a day, as well as the ability to provide care for those emergencies that we might see with regard to trauma, cardiology emergencies, as well as stroke care, including what are our primary as well as our quaternary centers here within Central Ohio. So Ohio Health Westerville Medical Campus, I did mention that briefly. That is a freestanding emergency department that is on a medical campus. Previously, Pickerington would have been included in this as well, but Pickerington 14 months ago did transition to a hospital. Westerville has 16 beds. It is staffed by board-certified emergency medicine physicians, and you're going to see that across the Ohio Health system, that a board-certified emergency medicine physician is on site. We also, most hours of the day, have the involvement of our advanced practice providers, whether nurse practitioners or physician assistants, as well as 2 to 4 registered nurses on site. Social work is there with limited hours, as well as pharmacy on site. We have general radiology, CT availability, as well as ultrasound. Again, in ultrasound, you're going to see limited hours across system just because of the limitations with regard to the ultrasonographers. The Ohio Health freestanding emergency departments, and when we talk about the freestanding emergency departments here within Central Ohio, you're going to pretty much be looking within a 270 loop. Looking up at the Ohio Health Lewis Center, you're going to see New Albany, Reynoldsburg, Obetz, Hilliard, and Powell. Ultimately, they are 8-bed sites. Again, you're going to see a board-certified emergency medicine physician that is on there. There may or may not be an advanced practice provider based upon volumes. And I will say that those sites within the east side and the southern portion of Central Ohio do see higher volumes and will have an advanced practice provider there, typically 10 hours a day. You'll see 2 to 4 registered nurses on site, as well as kind of that general radiology with the ability to do plain films, as well as CAT scans and the ability to do ultrasound during limited hours.
Mount Carmel's freestanding emergency departments function in a similar way to Ohio Health's. They're anywhere from 7 to 13 beds. Diley Ridge and Canal Winchester, it's a 13-bed emergency department where we have pharmacy and respiratory therapy, as well as ultrasound, CT techs, and registration. We just opened a new freestanding emergency department in New Albany. It's a 7-bed unit with respiratory therapy available, as well as a board-certified emergency physician, as well as 2 or 3 nurses. We've got similar staffing models over at our sites at Franklinton, and we also have a couple other sites, Diley, Reynoldsburg, at Franklinton, Lewis Center as well, which our group doesn't staff necessarily, but it is a Mount Carmel facility. Again, like Ryan said, ultrasound capability is limited at those sites, but for the most part, we can see a wide variety of complaints there. So I think what Ryan alluded to earlier, this is a resource guide through COTS. I think the whole goal in general about EMS transport to the freestandings is that we get the right patient to the right hospital in the right amount of time, the first time. And that's helpful to minimize resource use. It limits costs to the hospital system and the patient. Again, as we mentioned earlier, we operate under the auspices of EMTALA. So we have to coordinate with other emergency departments as far as transport and get to receiving and accepting physician from another facility. This slide, it goes through the wide variety of things that freestanding emergency departments can see, and we're going to go through shortly a list of cases that sort of highlights what would be appropriate to go to an emergency department and what might otherwise be better suited to go to a hospital-based emergency department.
So what might be best served going to a primary hospital-based emergency department? When you have a patient that has chest pain and you do 12 lead and you see what looks like a STEMI, or they look, even if it's not a STEMI and they're diaphoretic, and your gestalt is telling you, hey, this patient is something's going on cardiac-wise, we probably want to get that patient to a PCI center. A patient in active labor, if you're able to get to a facility, a primary hospital-based emergency department that does have labor and delivery on site, that's ideal. Trauma activation patients, and I would call out when we talk about trauma activation patients, in 2023, the American College of Surgeons did recommend that we look at our geriatric trauma patient with a different lens, understanding those ground level falls in individuals who might be on anticoagulation, ground level falls in individuals who may have a GCS less than 14. Elderly individuals who have heart rates over 90, those may in fact be indications for trauma activation. And there was some pretty clear guidelines that we do need to look at the geriatric population through a different lens than the general population, particularly as we evaluate our trauma activations. Postoperative complications are going to benefit from going to the main site where they had that surgery. Many times, we can see that, especially like I talked about earlier with diversion that's present. It's a recommendation. It is not a definitive, for a patient. If a patient had surgery at Mount Carmel East and they call and they're a week out and it appears to be a postoperative issue, getting that patient at a facility where they're going to be able to have connection with their surgeon is going to be key, especially when we end up in issues with citywide diversion and trying to transfer a patient from one site to another after workup has been done. It delays getting them in front of the person. Acute psychiatric emergencies. There are instances, where, patients may require additional crew backup just to get them to the hospital. Taking them to a freestanding emergency department where we do have protective services on site, but that's one protective services individual. And I can speak, with regard to what we see, sometimes in cases like that where I'm at Riverside and I need the backup of 4 or 5 of my protective services individuals to ensure safety of the patient and safety of our staff. We just don't have that in a freestanding emergency department. And in those instances where, hey, you're calling for backup just to transport the patient, taking them to a freestanding emergency department may not be ideal. The same goes with intoxicated patients who can be, a ticking time bomb at times until that patient may become more agitated, and want to make sure, obviously, we have that backup that because of those limited resources that exist within freestanding emergency departments, just ask that there be a level of respect of what we are able to do, as well as what's safe for our staff.
Another topic that's mentioned in the flow chart there, but not in the bulleted list, is stroke patients. Those should go to stroke certified centers. We can certainly evaluate them at freestanding emergency departments and give tenecteplase and thrombolytics as needed and as indicated. But at the end of the day, if they do have a large vessel occlusion that's going to need thrombectomy, the quicker we can get to a facility that has those capabilities, the better. A couple other nuanced bullet points would be something like a cold or pulseless extremity that would need, emergent evaluation by a vascular surgeon. Some other things to consider would be a rigid abdomen, possibly with some unstable vital signs. Those are some things to think about when transporting to a freestanding. I think thinking about the definitive care that the patient's going to need is something that is helpful for the patient and the facilities in Central Ohio as well. So this slide's going over unstable patients in the pre-hospital environment. So in general, we understand the capabilities of EMS, and oftentimes, some of us have spent some time in ambulances and things like that. So we're very appreciative of the pre-hospital care that goes on, recognizing that, undifferentiated patients are seen by EMS agencies regularly, wherever they may be, however sick they may be, and they have to, and you have to, kind of condense a wealth of information in a short period of time and make a disposition plan. With all of those things, we understand that it can be difficult to get guidance on a patient or make the appropriate decision in that moment. We're always available with medical direction to provide assistance as well at freestandings to determine if that's something we're capable of seeing or not. So don't ever hesitate to call in and ask if that's something that we're capable of. In general, things that are unstable in the pre-hospital environment, like cardiac arrest and difficult airway. If you can't oxygenate, can't ventilate, I think going to the nearest emergency department is probably a reasonable thing. For example, I had a patient in Diley Ridge in Canal, several months ago, and it was a cardiac arrest, and the patient had a trach that had been dislodged, and we had put a 6.0 endotracheal tube back in the tracheal site, and Chief Rosk and EMS was on standby and transported that patient to an appropriate facility where they could get definitive care. So I think oftentimes these, we're happy to see patients, and we're always there to educate after the fact.
And that's where, just kind of to piggyback on that is, if there are instances where, you're transporting a patient and you do need that extra, assistance, pulling into the, freestanding emergency department to get the patient in an area in a resus room where we have, more individuals, and perhaps even staying on site in those instances and helping in being one member of the team that helps to continue to work that patient together, understanding that definitive level of care may be beyond the freestanding emergency department. We talked briefly too a little bit about kind of the limitations of staff, but also resources within the freestanding emergency departments. Most, if not all, of our freestanding emergency departments have emergency department cots. Those are hard. They're hard for a reason. That's what they're built for. They're built so we can break them down quickly if we need to, work a patient. But that also means we don't have hospital beds, which for, elderly patients that don't have a lot of subcutaneous tissue to offset, areas of pressure, that they're going to be apt to develop pressure sores from some prolonged stays that may happen, working on getting them to that definitive level of care if it's something they need, to go to a main hospital for continuation of care. So something to just, think about, with regard to that. Also, we have no cafeterias. They're not hidden in the basement, nor upstairs. Many times we're limited to, frozen meals, which are cardiac patients in particular, and those with, heart failure who we might want to limit on low sodium diets. Try and find frozen food that doesn't have a lot of sodium in it. It's just, it's a challenge we have in making sure that these patients get that totality of care that they need.
So the first scenario we wanted to go over with you here, and something that you probably regularly see in the field is, let's say a patient calls 911. It's a 20-year-old male with sudden onset flank pain. It's been going on for 4 hours. The patient looks uncomfortable, has nausea and vomiting, with otherwise stable vital signs. An IV is established, and you give the patient Zofran, and the patient's nausea improves, but he's still in distress and having some flank pain. I think looking at a scenario like this is something I think is completely reasonable to bring to a freestanding emergency department. He's a young gentleman. Let's say he's got limited medical problems. It looks like a kidney stone. Let's say the patient has a history of kidney stones too. This is something that, comes to the freestanding emergency departments very regularly, and, oftentimes can be discharged from a freestanding emergency department. This guy, he's young, he's not, 80 years old. You don't think we're worried about a ruptured AAA. He's also, again, hemodynamically stable. And I think it would be completely reasonable, to see something like this at a freestanding. I think that, looking at a slide like this, you have to consider other medical problems, and if this patient, could have, a history of significant surgeries in the past. But I think in general, this is a cut and dry transfer to a freestanding emergency department.
So this scenario, we have a 35-year-old patient who's combative. They're confused and combative upon your arrival at the scene, ultimately requiring you calling in additional backup, having 4 total crew members, to help with transporting this patient to the hospital. Ultimately, utilizing ketamine, a total of 300 milligrams IM, to help better control the situation for the patient safety as well as staff safety. Your vitals, you've got a patient who's tachycardic with an acute psychiatric emergency, or perhaps, if this was something from like intoxication with something like methamphetamines, which we're seeing with increased frequency, could see that as well. And patients ultimately on a non-rebreather after that dose of ketamine. This is something, again, where I would defer to, getting to one of our main hospital sites. Having the backup of additional protective services is going to be beneficial, just again for that patient safety as well as the safety of our staff. And if we can get to a main hospital ED, that is going to be also if a patient does have an acute psychiatric emergency, where we have appropriate team members in place on site that are going to be able to help that patient, including social work, which we don't have within the freestanding emergency departments. And again, looking at those 4 crew members that are involved in maintaining safe transport of the patient, taking him to a site where you might have 8 beds and have already 10 patients on site with a waiting room that's full, and have 2 nurses, a physician and a rad tech, as well as protective services. You're going to require a lot of those resources to help with controlling the situation and ensuring safety. And we do have more of those resources, which are ultimately going to be best for that patient, for our staff in the long run.
And I think it brings up a good point about the amount of security that we have at our sites. I know that Mount Carmel's freestandings, we have typically one security officer who's armed, but other than that, the security services are limited. So a patient like this is going to require multiple staff members exposing themselves to injury and things like that, while other patients continue to walk into the ER with their mild complaints. But that's going to be a huge resource draw, at many of the freestandings that they come to. So this third scenario, it's a 40-year-old intoxicated patient who fell from a bar stool. The patient was picked up from a bar. He's confused, obvious signs of trauma, otherwise neurologically intact. The patient has no one essentially to corroborate the story of what happened. And his vital signs, although he's on room air and he has otherwise stable vital signs, he looks bad. Alcohol, patients who have alcohol use disorder, and the elderly are very prone to intracranial hemorrhage after trauma. These patients who have no bystanders available to corroborate any history. These are going to be sick patients that are going to need to be transported to a trauma center. Obviously, if a patient like this came to a freestanding ER, we would get all the appropriate imaging studies and stabilize her to the best of our ability. But at the end of the day, if this patient has an unstable cervical fracture or intracranial hemorrhage with shift or something along those lines and needs definitive care, he'd be best suited to go to the nearest trauma facility.
And just to kind of piggyback on that as well, a lot of times, individuals who may be intoxicated may require some additional recommendations, even kind of pre-hospital wise about, we got to get you into the hospital. We got to make sure you're okay. But a lot of times once they get to the hospital, it's not just that redirection pre-hospital wise. It continues to require redirection while they're in the hospital of why they're there. Particularly if you have a patient who might, solely be concussed and, fortunately not have an intracranial hemorrhage. They may be, reiterate why they're there, making sure that they're in a safe, place, safe condition, and require that, staff presence many times, at bedside almost consistently because of their condition where they just don't recall the events on the alcohol on top of the head injury. So something just to be aware of that if a patient's requiring some clear guidance of yes, you do need to go, in an instance like this, a lot of times it doesn't just they don't say okay and then just go to the hospital. Once they get to the hospital, they continue to require some additional guidance with regard to that. So this scenario, you've got you get called to a home of a 46-year-old known COVID positive patient, which I would venture to say, hopefully we're, outside the window where we're seeing this with the frequency that we saw, 5 years ago, which is in and of itself a feat to say that was 5 years ago. But you arrive at the patient's home to find them tachypnic. They're sitting on a recliner. Ultimately, he's on day 7 of symptoms and had tested positive 6 days earlier. Ultimately, on room air, patients satting 75%. You get him on 4 liters nasal cannula, and you have good waveform satting 94%. This is an instance where obviously this individual is going to require continued oxygen. It's not going to be a short-term administration of oxygen. And arguably still, if a patient opts to initiate, inpatient antivirals, we would, consider that, as well as continued inpatient care to maintain stability with that persistent hypoxemia. And this goes for any type of viral condition, any type of respiratory condition, not just COVID. If we have an individual who, is previously not on oxygen and all of a sudden requiring increased levels of oxygen, many times that's indicative of, hey, they're going to require, likely some inpatient level of stay, which we don't have within a freestanding emergency department. This is where we'd be looking to see what we do have in terms of getting him to kind of a bed in an emergency department within a hospital-based emergency department.
This last scenario, it's a 70-year-old witness arrest with a difficult airway late in the day in Powell. The EMS was called to the patient's home to find a patient having active compressions being performed, and of course the patient's morbidly obese. So you guys show up to the home and are unable to establish airway despite multiple attempts. Like I alluded to earlier, I think obviously this is a critical patient. Depending on where the patient lives, this patient clearly its family was concerned that the patient was pulseless. You can't establish an airway. You've tried several times, maybe used RSI, and so now the patient has paralytics on board. And so this is one that I think it would be if it's close to a hospital-based emergency department, may be best suited there. If this patient's going to need ENT involvement or need a evaluation by Palm Critical Care. But certainly, this is something I think, it wouldn't be unreasonable to bring to a freestanding if this patient needs immediate access. We've got, glide scopes in the emergency department and other resources at freestandings where we can maybe get a better view of what's going on. Again, we have several other staff members there that may be helpful in assisting us, and sometimes it's very difficult in the field to get airways. But and I don't know what your guys' thoughts are on this, but I think if it's reasonable to get to the patient quickly to a hospital-based emergency department, then we can get them there where we have quite a bit of backup. But if absolutely there's no ability to get an airway in the field, then we can certainly assist at a freestanding emergency department.
Yeah, and I would second that. If there is something where in an airway or any type of resuscitation where you do need kind of an extra set of hands, and perhaps it's going to be delayed transport. And I think knowing that it's 5 p.m. Up in Powell or certain areas, down in Canal where, you do hit significant traffic, and it may delay your transport getting to a main hospital. Being able to get that patient in a resus room where we have the ability for glide scope, we have a bronch, we have the ability to do kind of a crike if need be, as well as get more hands on deck to do everything we can to provide care for that patient, but also staying on site staying there, being an active member of the team, to see what we can do to help this patient in their time of need. And if you are going to have that delayed transport, getting to a main hospital, because it sounds like regardless, this patient needs to be at a hospital. But if we need those resources, as well as, some of those resources are just the personnel that are available within some of the freestanding emergency departments, not unreasonable to call to transport there as a temporizing measure.
So this last slide, I will say that, I've been the medical director at Reynoldsburg for 2 years now, and I'm always amazed at, the pre-hospital care, that's taken by, the EMS agencies in Central Ohio. And in general, I very rarely ever have a discussion with EMS agencies or the EMS medical director. So I think, and I think they would agree that, the pre-hospital care, is done very well. With that said, sometimes there are these cases that, may require a little bit of education, or maybe there was some nuanced care, that where we can kind of tease out, what we could have done in certain circumstances. And if there's ever any concerns, between the EMS transport to that specific freestanding emergency department, there can always be a discussion with the medical directors at those sites, or the EMS liaison at that site, or the EMS medical director. I think, oftentimes we resolve things pretty quickly, and oftentimes it's just a short course of education, both for physician or provider or the EMS agency.
Yeah, I think when EMS first started to utilize freestanding emergency departments, we had more concerns, more disagreements. When I get involved, my first comment to the EMS provider is don't put the patient in the middle. If you have some disagreement, the conversation should be held outside of earshot of the patient or the family members. You should always act in the best interest of the patient. The freestanding facility, once the patient's on campus, is obligated to provide a screening exam and stabilizing therapy. Part of that might, though, involve the patient getting back in the truck and going somewhere else, depending on the circumstances. And I think all EMS systems and all hospitals or systems have well-defined procedures to follow up on patient care concerns. And, getting into a public disagreement doesn't fix anything. I think it's keep the conversations private, do what's in the best interest of the patient. That may from time to time mean stabilizing care, back in the truck, next stop down, and then give us an opportunity to follow up as appropriate. Sometimes things are, sometimes staff and others just don't understand what the circumstances are for EMS. Trauma triage sometimes is a question. If the patient doesn't hit trauma triage criteria for trauma center, then potentially the patient could be served at a freestanding. So those are things we have to talk through, and a lot could be done after the fact, but don't put the patient in the middle. At least that's been my approach.
And medicine is a practice, and the sense that it is a practice is we can always learn more. We can always learn more about how to do things better, and that's ultimately our goal at end all and be all, is how can we treat the patients in a better way, and that is our goal. Anytime things come up, is if this should happen again, how can we approach it in maybe a different light to make sure that care is better. Ultimately, one comment I will make as well is sometimes in our freestanding emergency departments there may be a call out to 911 for interfacility transport. That is an instance where you have to realize you have a board certified emergency medicine physician who works at Mount Carmel East, Mount Carmel St. Anne's, works at Riverside or Grant, and knows that I got to get this patient to that site and I need to do it fast. Many times they've exhausted other opportunities with some of the private transport companies, which we work extensively making sure we have those protocols in place to make sure that those facilities and those other EMS agencies can come in a time-sensitive fashion. But in instances where they cannot, we have no other option. And when an emergency medicine physician is calling from a freestanding emergency department and asking for the assistance from 911, I would just understand that that is a real call for help, and their largest concern is that patient that's in front of them, because of the breadth of knowledge they have, as well as the respect they have that all of you in the pre-hospital environment provide to our communities. They understand that that involves taking you out of service for other potential emergencies, but that emergency that is at a freestanding emergency department is a time-sensitive emergency that they need to get to definitive care.
Yeah, we've talked about this. We've come to agreement. If a patient is hemodynamically unstable, we transport to the closest facility, regardless of affiliations. If the patient has a time-critical event but is hemodynamically stable and arrangements have been made for the patient to go to a defined facility, then we will transport the patient to that facility. And the only codicil to that is EMS gets to decide if the patient's stable or unstable, because they're the ones who have to provide the care in the truck. And I think that's coming to that consensus is a big step forward compared to what we were talking about 3, 4, 5 years ago. So hopefully it's not as big an issue. Okay. Any other comments? I was going to ask some questions, but you guys covered them in the last 5 minutes. I do want to acknowledge 2 things. First, greatly appreciate your time with this. And the other, as was mentioned in the first part of the conversation, was there's no doubt in my mind that 5 years ago we would have totally drowned if we didn't have freestandings doing 100 COVID screens a day. The hospitals were already busy, and freestandings do serve a purpose in our world. And I think it's really to the betterment of our population. So, any closing comments, guys? If not.